Hey, this is Shannon Finks with the Finks 5, and today I have with me Dania Quran, who is a fourth year pharmacy student.
And I'll be discussing insulins. Insulin is a hormone that is secreted by the beta cells of the pancreas and is essential for the metabolism of glucose. Remember that type 1 diabetes is caused by insulin deficiency, while type 2 is caused by a combination of insulin deficiency and resistance. We use insulin to restore the body's natural ability to use what we eat as energy and to manage glycogen stores. Insulin does a couple of important things. To begin with, it takes glucose from our diet so that our cells can use it as energy. Insulin lowers the glucose from the blood by facilitating its uptake into the adipose and muscle tissues. When we have adequate energy, glucose is stored as glycogen in the liver. When insulin is not working correctly and our cells don't have enough energy, glycogen can be converted to glucose. Before we discuss the different types of insulin available, let's just review on how to dose in type 1 diabetes. Per ADA, you will start off with an average total daily dose of 0.5 units per kilogram per day, which will be divided into basal and rapid insulin in a 50-50 split. The rapid insulin will be further divided between the 3 meals that the patient will eat. Later, when you are adjusting the patient's insulin, you may have to use the rule of 500 or the rule of 450 to compensate for what the patient is eating. This is a calculation that is unique to each patient based on their carbohydrate intake. Remember that the rule of 500 is for the rapid-acting insulins, while the rule of 450 is for regular or short-acting insulins, and you want the basal and rapid insulins to be in that 50-50 ratio. For type 1 diabetics, if their pre-meal blood sugar is out of the targeted range, the meal-related insulin dose may need to be adjusted accordingly. To return the blood sugar to the desired pre-meal blood sugar, it is necessary to determine the amount of blood glucose that is lowered by the injection of 1 unit of insulin. The amount of blood glucose that is lowered by the injection of 1 unit of insulin is called the insulin sensitivity factor, also known as the correction factor. This slide contains the formulas to determine both the correction factor and the correction dose. The rule of 1500 is used to calculate the correction factor for people who use regular or short-acting insulin, while the rule of 1800 is used to calculate the correction factor for the people who use rapid-acting insulins. Here's how you determine the correct insulin dose for type 2 diabetics. Insulin is used in type 2 diabetes in patients who are uncontrolled on multiple oral agents, or their A1C is above 10%, or their blood glucose is above 300 milligrams per deciliter. Also be careful when switching from one insulin to another. Most conversions are 1-to-1, but there are some exceptions, so always double check before switching your patients to a new insulin. Consideration of hepatic and renal function is important to keep your patients safe from hypoglycemia. Newer agents may be preferred because their pharmacokinetics are unaltered in chronic liver disease, therefore they have a lower risk of hypoglycemia. If your patient has kidney dysfunction, you may need to decrease the insulin dose and adjust based on their response. Before we discuss the different types of insulins, I want to show you this graph which demonstrates the onset, peak, and duration of action of the common insulin types. Notice that degludec, detamir, glargine, and to some extent NPH are very long-acting and are options for basal insulin, while your rapid and regular insulin are meant to be quick onset and offset, and are used around meal times. Of note, regular is always used in pumps. When food is consumed, the rapid-acting insulins listed here provide a bolus dose similar to the pancreas releasing more insulin in response to food intake. FEOPS is a newer form of aspart which contains vitamin B3 for faster absorption. Any of the rapid-acting insulins can be given immediately, during, or right after meals. If patients have a fear of injecting themselves, they can be prescribed Afrezza, which is the only inhaled insulin available. However, be aware that their side effects and safety profile differ from the injectable insulins. This is not commonly dispensed. Here are the different forms available for each of the rapid-acting insulin. Note, Humalog concentrated disposable pens containing 200 units per ml is indicated for patients who require more than 60 units of a rapid-acting insulin per day. This is the only rapid-acting analog insulin available in concentrated forms. Here are the short-acting insulins. Regular insulin can provide mealtime insulin, but has a slower onset than rapid acting and lasts longer than needed for a meal. It is injected 30 minutes before meals. Also note, regular insulin is often given with NPH. Any percentage mixture of NPH and regular insulin can be made by mixing the two insulins in the same syringe, but you must draw up the regular insulin, which is clear, before the NPH, which is cloudy. So remember, draw up the clear before the cloudy. Humulin R U500 should only be for patients requiring more than 200 units of insulin per day. Although the onset is quick, please be aware it has a longer duration of action. NPH is an intermediate acting insulin. It has fallen out of favor due to its unpredictable duration of action. When taken before breakfast, it can peak in the middle of the afternoon, or if taken before dinner, can peak during the night. These peaks can cause hypoglycemia. If your patient does have nocturnal hypoglycemia, you can give 2/3 of a dose in the morning and 1/3 at bedtime to counteract this risk. Despite its shortcomings, it is still affordable, and that's why patients may still be receiving it. Basal insulin, or long-acting insulin, provide background insulin similar to the pancreas continuously secreting a low level of insulin. Note that these insulins are given once a day, usually at bedtime, and you cannot mix it with any other insulins. Basaglar possesses a PK profile similar to Lantus, but it is not the official generic version of Lantus, so a new prescription for Basaglar is required when switching from Lantus to Basaglar, which is a 1-to-1 conversion. Note, Toujeo is a more concentrated version of insulin glargine. It significantly reduces the incidence of nocturnal hypoglycemia due to its delayed onset of 6 hours. Toujeo has a long duration of action of 24 hours, and therefore dose titration should not be made more frequently than every 3 to 4 days. Patients who had previously achieved glycemic control with Lantus require 12 to 18% increase in their total daily dose of Toujeo relative to Lantus to achieve similar glycemic control. Here are the different forms of long-acting insulins available in both vials and pens. Another Finks 5 will go through the different formulations and how to teach patients how to use these insulins. So we encourage you to listen to that one too. There is one ultra-long-acting insulin available on the market, which is Tresiba. Tresiba can be useful when the long-acting insulins cause nocturnal hypoglycemia. Prescribing the pre-mixed insulin pens will help eliminate any patient dosing errors. These are available in 70-30, 75-25, and 50-50 mixes. So be careful when dispensing these so that it's the right concentration. 50-50 is an option, but is not used often. Walmart provides a generic insulin that is available over the counter, which is great for patients that can't reach their doctor, don't have insurance, or their insurance doesn't cover their insulin. It's available in regular or short-acting, intermediate, and mixed 70-30 under the brand name of Relion. Each 10 milliliter vial costs about $25. Be sure to talk to anyone picking up generic insulin and make sure they have a glucometer to monitor their glucose response. Check out our Finks 5 on glucometers and other sensor devices. So for some clinical pearls on insulin. All insulins have the potential to cause weight gain and hypoglycemia. They are the preferred anti-diabetic agent in pregnancy and breastfeeding. And remember, regular insulin is the preferred insulin for all pumps. In summary, insulin is the drug of choice for type 1 diabetes and is often utilized in type 2 diabetes when A1C is greater than 10% or blood glucose is greater than 300. New insulin formulations with more favorable pharmacokinetic profiles provide greater dosing flexibility, reduce risk of hypoglycemia, and reduce patient burden. Patient preference as well as easy-to-use formulations should be considered when choosing an insulin product.
Thanks so much to Dania Quran and Dr. Jennifer Campbell for preparing and peer reviewing this Finks 5. We hope it was useful for you.